Okay, we're going to start with care of the patient with inflammatory intestinal disorders. This includes appendicitis, peritonitis, ulcerative colitis, Crohn's disease, and diverticular disease. Appendicitis, an acute inflammation which occurs when the lumen of the appendix is obstructed. This leads to infection as bacteria invade the wall of the appendix. The obstruction is usually from very hard pieces of feces known as fecaliths, F-E-C-A-L-I-T-H-S. The mucosa secretes fluid, increasing internal pressure and restricting blood flow. This is what causes the pain. So again, with any type of inflammatory process, like we've been talking about all trimester, part of the inflammatory process is swelling. So we have edema. This causes pressure because it's coming from inside the appendix and it's pressing out toward the wall. Well, this increases pain. The more pressure, the more pain. So the more pressure, we also start to have decreased blood flow to this area. And then the decreased blood flow can also cause the tissue to die and we have pain. Assessments. Sequence of symptoms. This is important when you're assessing anyone that comes in with complaints of GI issues. For appendicitis, usually the abdominal pain is before, the nausea and vomiting. The abdominal pain comes before the nausea and vomiting with appendicitis. The abdominal pain itself is what can be causing the nausea and vomiting. The pressure from the appendix swelling can cause the nausea and vomiting. If you have nausea and vomiting before abdominal pain, that may indicate gastroenteritis. You may have contracted something viral or bacterial that is causing the inflammation and causing the nausea and vomiting. Cramp-like pain in the epigastric or the periumbilical area. Peri means around, umbilicus is your belly button, so around your umbilicus. They can have anorexia, where they don't have the desire to eat. It's probably because they're having abdominal pain and they're nauseated and vomiting. Moderate elevation of your white blood cells from 10,000 to 18,000. A white blood cell greater than 20,000 may indicate a perforated appendix. What does perforated appendix mean? It means that it has ruptured and the contents have gone into the peritoneal cavity, and that is causing even a wider spread inflammatory response. So that's why the white blood cell count is elevated. Pain can initially present anywhere in the abdominal area, but as it worsens, it shifts to the right lower quadrant between the anterior iliac crest and the umbilicus. That's called McBurney's point, and I have a picture of that coming up. So with appendicitis, the peak incidence is usually between 10 to 12 years. It begins as a dull, steady pain in the periumbilical area. It progresses over 4 to 6 hours and localizes to the right lower quadrant. Clients could run a low-grade fever. We already mentioned nausea and anorexia. Sudden pain relief may indicate rupture of the appendix. Why? We have all this pressure building up inside the appendix from the swelling, the edema from the inflammatory response. So that is what's causing the pressure. If the appendix ruptures and that pressure is suddenly released, then no more pain. But now we have the contents of the appendix out into the peritoneal cavity, and that can cause peritonitis. To diagnose, we're going to look at their clinical signs and symptoms. We're going to look at check to see if they're elevated white blood cell. We're going to do an abdominal sonogram, also known as an ultrasound. Those can be done portable. Exploratory laparotomy to go in and see if it is the appendix that is causing the pain. And again, rebound tenderness at the McBurney's point. Here's a picture of McBurney's point. It's located midway between the anterior iliac crest and the umbilicus in the right lower quadrant. Some evidence is coming out that we don't want to assess for rebound tenderness anymore, because as you press in on the appendix, you cause even more pressure to increase, and that can cause the appendix to rupture prematurely. Management of someone if we suspect them to have an appendicitis. We're going to keep them NPO. We're going to keep them NPO because we don't know whether we're going to rule in the appendicitis and then they would go to surgery. So we're going to keep them NPO. We're going to plan for that ultrasound at the bedside. That's going to let us know if the appendix is swollen. And we can also, a CT scan would help with that. We're going to administer IV fluids because we're keeping the patient NPO. Plus, if they were already nauseated and vomiting, they'd already lost fluid volume. We're going to remain in a semi-Fowler's position. This position will help decrease muscle tightening in the abdominal wall. Because if you lay these people down flat, your abdominal wall muscle is going to come tighter, and that puts pressure up against the appendix also, and that's what's causing the pain, pressure. No laxatives or enemas. If we give someone laxative or enema, we've increased the pressure in the GI tract, and that could cause the appendix to rupture also. We do not want to apply heat to the abdomen. What does heat do? Heat dilates. We do not want to dilate the appendix, the cells of the appendix, and have more blood flow to an area that is already more swollen. It's already swollen. That would increase the pressure. Management of confirmed appendicitis. We're going to get these people ready for laparoscopic versus a laparotomy or open appendectomy. Depending on the person's size, obesity usually plays a role in whether or not they have it laparoscopic or a laparotomy or open. Because if they have to go through a lot of adipose tissue, open is the safer way. Good in laparoscopic, you've got 3 or 4 small incisions. The laparotomy, you've got 1 large incision. They also have a new procedure. It's natural orifice transluminal endoscopic surgery. It's called NOTES. And the concept of this procedure is you go through a client's natural opening. Say for a woman, it'd be the vagina. So you'd go through the vagina to locate the appendix and remove it without having to make any other incisions. Post-op care is going to be the same. We're going to continue to give them IV fluids because they've been NPO before the surgery, possibly nauseated and vomiting before the surgery. And then we're going to keep them NPO after the surgery until they wake up, and then we will slowly advance their diet, starting out with clear liquids. IV antibiotics, because if the bacteria that has invaded the appendix and causing this whole process, we want to try to knock that out with antibiotics. Opioid pain medication. They're having pain. If they have pain, they're not going to want to take deep breaths. They're not going to want to listen to anything that you're teaching. So we want to get their pain under control. Now we got to give them stool softeners. A couple of reasons for this. Stool softeners are going to help them not have to strain to have a bowel movement. So if they're waiting to go to surgery, we don't want them to have any increased abdominal pressure because that could cause the appendix to rupture. After surgery, we do not want them to have any pressure up against their incisions. And we want these people out of the bed as soon as possible. Why is that? That's with any patient. After surgery, we want them to get out of the bed and get up and move around. If they're out of the bed moving around, they take deep breaths so we don't have pneumonia. They have better peristalsis, so it decreases our risk of a paralytic ileus. And if they're up moving around, we have increased venous return to our heart of our blood, so we decrease our risk for DVT. Peritonitis. Acute inflammation of the visceral parietal, same thing, peritoneum and endothelial lining of the abdominal cavity. It occurs when the inflammatory reaction fails to wall off the offending organism. The organism can be bacterial or chemical, and it becomes widespread in the peritoneum. So, if we had bacteria that invaded the appendix and caused the appendix to rupture, now that bacteria is in the peritoneal cavity. Now it's causing infection and inflammation in a larger area. So now we have a larger area going through the inflammatory process, and we're going to have even more swelling. Now, when you think of chemicals, don't just think of external chemicals, think of inside. Like your gallbladder. Your gallbladder produces bile to help with the digestion of food. Well, bile, if it's in the peritoneal cavity where it's not supposed to be, that is an offending chemical. It's causing irritation, inflammation in the peritoneal area. So bacteria gain entry by perforation from appendicitis, like we just mentioned, diverticulitis, which is inflammation of the diverticulum in the colon, peptic ulcer disease, a gangrenous gallbladder, a gallbladder that's become infected, bowel obstruction, ambulatory peritoneal dialysis. Now, this is where the patients have the dialysis catheter, the peritoneal dialysis catheter, through the skin, through the abdominal wall, into the peritoneal cavity, and they do their exchanges, their dialysate exchanges at home, usually during the day, and then it sits during the night, and then they drain it the next morning. So that is a direct portal entry for bacteria to go into the peritoneal area. Chemical peritonitis, like I said earlier, is from leakage of bile, pancreatic enzymes, and gastric acid. So that's your chemical. How does this become life-threatening? How can peritonitis become life-threatening? Well, when there is a delay in treatment, that means that this bacteria or chemicals are in the peritoneum for a while. We didn't treat them. The body continues to have to fight the offending organism. So we've got an inflammatory response in a large area occurring. So blood is shunted to the area of infection. That's called hyperemia. Now, fluid is shifted from the extracellular compartment into the peritoneal cavity. That's third spacing. So keep in mind, we got a volume shift. So what happens when volume is removed from the circulatory system? Y'all know this. We've already done it this trimester. Hypovolemic shock. Because we have decreased circulating volume, making us have a low blood pressure, and this can cause decreased perfusion to the kidneys. And decreased perfusion to the kidneys can lead to kidney failure. If we have kidney failure, we have problem controlling our electrolytes. Electrolyte imbalances, especially the potassium, can lead to cardiac arrhythmias. So you see how this all progressed? Somebody coming in, having some signs and symptoms of appendicitis, diagnosis of appendicitis. If the appendix ruptures before we take them to surgery, see how this snowballs into worsening problems. Other complications that we can have, peristalsis can slow or stop due to inflammation and fluid retention because the peritoneal cavity is becoming flooded with the fluid, so it's pushing against the colon, and that's going to slow down our peristalsis, could even stop it. Bacteremia, the bacteria that entered the peritoneum is now can translocate into the bloodstream. So now we've got bacteria going all through our bloodstream, all through our body. Respiratory problems, because we've got increased abdominal pressure, that's not allowing our diaphragm to drop down, so we can't take as deep of a breath. So if we can't take as deep of a breath, we have less lung surface volume to have O2-CO2 exchange, so our O2 can decrease. We're going to assessment of the patient. We're going to ask about any fever. How long have you been having any fever? How high did it get? Determine the character and location of the pain. We need to find out which section of the abdomen the pain started. That would help us figure out which organ that may be causing the problem. When you assess their abdomen, it's going to be rigid, board-like. I mean hard. Not just distended and tight, it's going to be hard. If you're sitting at a desk, knock your hand on the desk, and that is how hard it's going to be. Abdominal pain and referred shoulder or chest pain. You have the rebound tenderness. The tenderness can be localized or general. If this has been going on for an amount of time, the tenderness will have spread from whichever quadrant it started in, that it was initiated, and it's covered more of the peritoneal area, so you're going to have a more generalized abdominal pain. Nausea and vomiting. Dehydration. We've got decreased urine output and tachycardia. Why would we have those? Well, that's our body's way of compensating. We've lost intravascular volume because now it is in the peritoneal cavity. So we have a decreased blood pressure. Well, what does our body do to compensate for that? We are holding on fluid. So we're going to decrease our urinary output. We're going to increase our heart rate. So we have the tachycardia. Compensating mechanisms for volume. We've got poor skin turgor. Diminishing bowel sounds. Inability to pass flatus or feces. So again, we've got all this fluid coming into our peritoneal cavity. It's putting pressure against our colon. If we put so much pressure against our colon, we can't have peristalsis, or we slow peristalsis down. Then we're going to have decreased passing of flatus and decreased passing of stool. Hiccups, diaphragmatic irritation. So we got the peritoneal cavity increasing with fluids, pushing up on the diaphragm. It's causing it to be irritated. We just mentioned the respiratory compromise because the diaphragm can't drop down and allow for full volume lung expansion. Lab test. We're going to do blood cultures. Well, we just said we've got translocation of bacteria into our circulating blood system. So we need to check to see what bacteria is growing in there. White blood cells. We're going to check for our white count, which helps us with infection. CMP, chemistry panel. We've got to especially keep up with our electrolytes because we've had a fluid shift. When we have a fluid shift, what happens? Sodium and chloride go and water follows. So that all went to my peritoneal cavity. So what's left in my circulating blood? I've got the appearance of dehydration, and my potassium may be hemoconcentrated, so it could be elevated. KUB, which stands for kidneys, ureter, or bladder, that is your abdominal x-ray, or you can have abdominal ultrasound. Management, we're going to give them IV fluids because we're keeping them, two reasons. One, we're keeping them NPO because we may need to go to surgery. Two, IV fluids. Didn't we have this fluid shift into the peritoneal cavity? So now we've got to increase our circulating volumes. IV fluids, IV antibiotics, because we just said we had a bacteria that got translocated. They're NPO. We don't need to have anything in the GI tract while we're trying to figure out what's not working. Plus, they may need to go to surgery. NG tube. Let's decompress the stomach. Let's get out any air, any digestive juices, any food, anything that was in the stomach. Let's take that out because that's going to decrease pressure in the abdominal cavity. Monitor INO and daily weight. We just said we may have a change in our output because we're trying to retain fluid to make up for our displaced volume. Daily weight. We need to see if we're gaining weight because my fluid volume keeps going into my peritoneal cavity instead of staying in my vascular system. Need to see if we're gaining weight. Oxygen. Monitor the pulse. Monitor with pulse ox. We just said it's going to decrease our ability to take deep breaths, so it's going to decrease our O2 CO2 exchange. So we need to monitor our O2 sat. Pain control. They're in pain. If we get the pain under control, they can take deeper breaths and pay more attention to instructions. Surgical consult. It's better to go ahead and have the surgical consult on board when things are not emergent at this point. The surgeon can come in and do a better assessment and talk to the patient more. Get them already on board so in case we do have to go to surgery, they're already ready. Exploratory laparotomy would be the procedure that would need to be done. Let's move on to ulcerative colitis. Colitis, colon, ulcerative, ulcers. What do ulcers do? Ulcers can eat through the lining until we get down to the vascular bed and we have bleeding. So put those two together. The exact cause of ulcerative colitis is unknown, but genetically, it's because it's been found in families and twins. So they think it has some genetic components and some immunological factors are suspected. So they've found some antibodies in patients with UC that are not found in patients without UC. ulcerative colitis as you see. With ulcerative colitis, there is widespread inflammation of the rectum and rectosigmoid colon that can extend to the entire colon. It does not involve the small intestine. Why do I point this out? Well, didn't we discuss at our last lecture that most of our nutrients are absorbed in our small intestine? So if I'm not having an issue with my small intestine, I'm not going to have to worry about nutrition as much. The intestinal mucosa has increased blood flow, it's edematous and reddened, the lining can bleed, and small erosions can form. So that's where you got the ulcerative. Abscesses then form over the ulcers and cause tissue necrosis. Edema and wall thickening lead to a narrowed colon, right? We're taking up some of the diameter of the lumen, and it can result in a bowel obstruction. Which type of bowel obstruction do you think it would be? Mechanical or non-mechanical? Well, since the lumen of the colon is decreasing in diameter, that would be a mechanical obstruction. You have increased risk for colon cancer due to cellular changes from long-term disease, because what happens in the process? You have a injury, a trauma. We have the inflammation process. Part of that is remodeling of the tissue, so the cells are growing to replace, to heal. Well, if you have to have that process over and over and over again, at some point the cells don't know when to stop proliferating, and they just keep on, and they become uncontrolled proliferating cells, and that's how it leads to the cancer. Peak age for diagnosis is 30 to 40 years and 55 to 65 years. Not sure why there's a gap there. Women are affected in younger years, and men during middle age and older adulthood. Got a classification. This is classification for severity. For mild UC, if you have less than 4 stools a day with or without blood and you're asymptomatic, your lab work is usually normal. You notice it's stools with or without blood. Moderate is more than 4 stools a day with or without blood. Minimal symptoms of abdominal pain, because again, you've got the inflammation causing the swelling. That's what's going to cause the pain. They have nausea. They have a possible increase in the CRP and the ESR lab values. Well, what do those measure? CRP and ESR measure inflammation. Severe would be greater than 6 bloody stools a day. Start running fever because the inflammation process has been going on longer, possibly over a larger surface area. Going to start seeing the tachycardia. Why are we seeing tachycardia? Because we're having greater than 6 bloody stools a day. We're losing that volume. So that's going to make the heart rate go up. Anemia, we're losing blood. It said bloody stools, so we're losing blood, so we're having some anemia issues. Abdominal pain. The CRP and ESR would be even more increased because we've had more time for inflammation to be developing, plus it could be covering a larger area, surface area. Fulminant classification. Fulminant means flashes of pain. So fulminant is greater than 10 bloody stools a day. You're having increasing symptoms, and you've lost so much blood at this point, your blood count may be so low that you actually require transfusion. And they have colonic distension on the x-ray. So it's going to show they've got such inflammation and swelling going on that it is actually going to show up on the x-ray. Assessment. Well, we need to collect family history because didn't we say that it possibly could be genetic? If it's genetic, we need to find out. Anybody else in your family experienced this? Recent use of antibiotics or NSAIDs, because those can cause inflammation of the colon. We need to make sure, is this actually ulcerative colitis, or could we relate this to something else? Ask about surgeries, any type of colon surgery. Nutrition. What is make them give you an example of, or have them give you an example of what a daily menu would be for them. Their bowel patterns. Are they having problems with constipation? How many times a day do they go? How many times in a week do they go? What is the consistency of their bowel movements? Have they had any recent trips to tropical areas? Because if they've been to tropical areas or something like Mexico, you could have gotten a bacteria from the water, and that's causing you to have the diarrhea, and it's really gastroenteritis, not the ulcerative colitis. So that's why we need to get this specific information. Their vital signs should be within normal limits. If severe ulcerative colitis, they may have a low-grade temp. And like I said, we've got to rule out any viral or bacterial infections, because those could mean other GI problems, not ulcerative colitis. Assess for abdominal distension and tenderness. We're going to do the CBC to check the white count. Also to check for inflammation with the white count. We're going to check our hemoglobin hematocrit to see what our status is. If they've been having blood in their stools, it could be low. We're going to look at our platelet count. If they've been bleeding and we're trying to clot it off, they may have a low platelet count. Their CRP and ESR would be elevated because those check for inflammation. Again, CMP, we got to check for our electrolytes, because we've had, see if we're digesting. And albumin level. We need to know what our protein level is. We've got to assess the patient's understanding of the illness and how it is affecting their lifestyle. So if they're having increasing diarrhea, they're not going to want to go to work. They're not going to want to go do anything social, any social functions, because they don't know if they're going to have another diarrhea stool. Plus, if they're losing blood in the stool, they could be fatigued. They could be having shortness of breath. So we also need to know, how are they with their activities of daily living? Are they able to complete their activities of daily living without getting short of breath? Colonoscopy is the most definitive test for diagnosis. Well, why is that? Well, colonoscopy takes pictures of the colon. Ulcerative colitis occurs in the colon. Okay. A CT scan can be used to also with this assessment. Barium enemas with air contrast can show differences between ulcerative colitis and Crohn's disease, along with the depth of involvement. Because also, if you think about it, Crohn's disease, we're going to get into that in a minute, but it's looking at the thickness of the lumen of the colon. Ulcerative colitis, you can have those small erosion areas in the large intestine. So that would be where that that would be where the barium would concentrate, in those areas of ulceration. Nutritional therapy with severe symptoms, you're going to keep them NPO, and we're going to give them TPN. Why? If we have an inflamed colon, do we want food running through it? No. It's not going to absorb and absorb the water, absorb the fluid of anything coming through it like it's supposed to, because its wall is inflamed. Elemental formulas that are absorbed in the small intestine can be used. So we have certain types of tube feedings that will become completely absorbed in the small intestine. So we can put in a NG tube or a gastric tube and have it go into, give these elemental formulas that are going to be digested in the small intestine, and it won't go to the colon. It won't affect the colon. Caffeine and alcohol can increase diarrhea and cramping. Raw vegetables, high fiber foods, lactose containing foods like milk can be poorly tolerated, because those are not going to all finish in the small intestine. It's going to go all the way through the colon, and we don't want to use the colon at this time. Rest and stress management can reduce some of the symptoms. So medications, you've got your aminosalicylates, or 5-ASAs, if you want to call them that. And they are on page 1152 in your textbook. So they're anti-inflammatory effects by inhibiting the prostaglandins. So they're going to decrease the prostaglandins function. But we need our prostaglandins for an inflammatory response, so we got to be careful with this now, because now we're affecting their immune system if we give these. So your aminosalicylates. So sulfazine, this one has unwanted side effects. If you notice, it's got the word sulfa in it. A lot of people have allergies to sulfa, so we need to be careful with that. Mesalamine, this one I've seen it used more often. It's better tolerated because it has no sulfapyridine in it, so that's one reason it can be tolerated. Rowasa is a form of a mesalamine, can be given as an enema, and Canasa, which is also a mesalamine, as a suppository. Therefore, they have less systemic absorption and less side effects. So, if I give you an enema or suppository, the medication is going straight to the colon and being absorbed through the colon, so it doesn't have to get into my systemic blood system and go through my kidneys and my liver. So that's why you have less of the side effects. We can give them glucocorticoids, right? Y'all know about these. What do? They're anti-inflammatories. These are given during flare-ups and then tapered off. But now you can have long-term effects from their use if you're having to use them. If you have a lot of ulcerative colitis flare-ups over your lifetime, you could start having some of the long-term use problems such as hyperglycemia, osteoporosis, peptic ulcer disease. And again, you got increased risk for infection with these because we're altering your immune response. Antidiarrheal drugs, they're having a lot of diarrhea stools. So fulminant, you can have greater than 10. So people want to take some Imodium or Imodium to decrease the stools. But you got to be careful with these because they can create colon dilation and toxic megacolon. You also have to be careful with these in elderly people, because it can cause confusion. Immunomodulators such as Remicade, Humira, again, we're affecting the person's immune response because we're trying to decrease the inflammation in the large intestine. But we can't just do it in one place. It's going to do it all over the body. So these people can be at risk for having other infections because we're decreasing their inflammatory response. All right, surgical management. Surgical management. They can have an ileostomy. An ileostomy is a loop of the ileum is placed through the abdominal wall for drainage of fecal material into a pouching system. Okay, so this you have some pictures of this on 1154 in your textbook. All right, the stoma is placed in the right lower quadrant below the belt line. It should not be prolapsed into the abdominal wall. This goes for any ostomy. It should be pinkish to red. If it looks pale, bluish, or dark, report it to the healthcare provider. If it's pale, it's not getting blood flow. If it's bluish or dark, it's not getting any blood flow. It's not being perfused. So this is with any ostomy, those criteria. Stool from the small intestine contains enzymes and bowel salts that can irritate skin around the stoma. Because what's happening here? We've got ulcerative colitis in the large intestine. So we're going to want to bypass my large intestine. So this ileostomy comes off of the small intestine and goes to the outside abdominal wall into a pouch. Well, if I'm coming through my small intestine, I still have a lot of my enzymes and the bile salt that the gallbladder put in there. If that gets onto my skin continuously, I'm going to have a real problem with tissue integrity, skin integrity at that site. Meticulous skin care is what we'll have to do here. Another surgical is the restorative proctolectomy with the ileo pouch and anal anastomosis. This is considered the gold standard, the surgery that would be done a lot for people who have ulcerative colitis so severely that it is affecting their lives, making them stay anemic all the time. What happens here is the removal of the colon and most of the rectum. The anus and anal sphincter remain intact. So this creates an internal pouch using the small intestine, which is then connected to the anus. So basically you're doing a bypass of the GI tract. You're going from the small intestine straight to the anus. We're bypassing the colon. They're taking that out. So an ileostomy is created to give time for these sites to heal up, and then it can be reversed. Usually it's about 1 to 2 months between the surgeries. Now, a total proctolectomy with a permanent ileostomy is removing of the colon, rectum, and anus with surgical closure of the anus. Now, I point this one out because, guys, when y'all take somebody's rectal temperature, you need to turn them on their side, spread their buttocks to find the rectum. Some people just they don't want to turn the patient, so they just bend their knees up and blindly stick the rectal probe in. Well, a nurse has caused perforation of an anal closure with this. They inserted the temperature probe, the rectal probe, so forcefully that this person had a total proctocolectomy but couldn't tell anybody he'd had that, and they tore right through the anal closure, and we had a bleeding problem. So always turn the patient on their side, I don't care who it is, to do a rectal temperature. All right, we're going to move on to Crohn's disease. Crohn's disease. Now, this is an inflammatory disease of the small intestine, the colon, or both. It can affect the GI tract from the mouth to the anus. It can skip sections of the GI tract. So I could have a section in my small intestine have an episode of Crohn's disease, and at the same time, a different area in my large intestine. So it can skip sections of the GI tract. But now, since this happens in the small intestine, or it can happen in the small intestine, I'm going to have to worry about nutrition more for a Crohn's disease patient, because they're not going to be able to absorb their nutrients. So this presents as a transmural. Transmural means entire thickness. Inflammation that causes a thickened bowel wall. Severe diarrhea and malabsorption of vital nutrients from inflammatory bowel changes. Therefore can become malnourished and dehydrated very quickly. Fibrosis and scar tissue develop and create narrowing of the bowel. So again, we've got a mechanical obstruction that can happen. Cause is a combination of genetics, the immune system, somebody's immune system, and environmental factors. Risk factors, you got Jewish ethnicity, tobacco use, and living in urban areas. Actually, almost 1 million people in the U.S. have Crohn's disease. When I was a new nurse, I didn't see very many cases of this, but I believe it's because we've gotten better at how to diagnose it. Wrong direction. Here we go. All right, assessment. We got to obtain a recent history of any unintentional weight loss. We need to know the frequency and consistencies of stool. We need to know, have you had any blood in the stools? Any fever and or abdominal pain. We got to evaluate their nutritional and hydration status. Didn't we just say it can affect the absorption of nutrients and fluids? So we got to assess this. Abdominal examination to assess for distension, masses, or visible peristalsis. Bowel sounds may be diminished or absent. Rushing sounds may be noted over narrowed areas. So if I've got an area of the colon that's becoming more narrow, that's a smaller area for fluids, stool and fluids to pass through. It's going to be a smaller area, so it's going to make a higher sound, higher pitched sound. So you may hear a rushing sound. If the disease is only in the ileum, where's the ileum? The ileum is in the small intestine. It's part of the small intestines. You'd have soft, loose stools that may occur 5 to 6 times a day. They may have steatorrhea. Steatorrhea are fatty diarrheal stools. We're going to check their CBC, their CMP, folic acid, B12, albumin level, CRP, and ESR. Now, why the lab that's different here than ulcerative colitis is what? The folic acid and the B12 level. Why is this different for Crohn's? Didn't we say Crohn's can happen anywhere along the GI tract? Where do we absorb our folic acid and B12? Stomach and small intestines. So that's why we have to add those labs here. Again, a KUB would help, a CT scan for assessing, and a bleeding scan. Management, nutrition. Well, these people are going to be NPO, and they would have, we'd start TPN on them during exacerbations. Why? We got to allow the bowel to rest. If the GI tract is irritated and inflamed, we cannot put any nutrition through it. You could use the elemental or semi-elemental products, can be absorbed by the jejunum. So again, that would be, we could, if we're not having any Crohn's in the small intestine area, then we can put these type of nutrition straight into the jejunum and get it absorbed there. Avoid carbonated beverages and alcohol. Again, we've got the 5 ASA drugs for mild to moderate disease. You've got the azathioprine and the mercaptopurine. Okay. Methotrexate. These suppress immune activity for moderate to severe disease. So any of these medications that are decreasing our immune response, they're going to work for ulcerative colitis, and they can also work for the Crohn's. Monoclonal antibody drugs inhibit tumor necrosis factor, which decreases the inflammatory response. That's what those drugs do. Infliximab or Remicade, get this IV. The adalimumab or Humira, you can get that sub-Q. And the Cimzia is IV. Glucocorticoids can be used, but could mask signs of infection brought on by abscesses or fistulas. Now, while we're talking about fistulas, with Crohn's disease, you can develop fistulas. You got a good picture on page 1158. Crohn's can cause inflammation to work through the mucosal lining of the intestine, and it can actually work through the wall and eat through to the skin, or work its way through to the skin. So if I have a fistula from my intestine to my skin, it's called an interocutaneous. Intero from the inside, cutaneous, skin. So if I have one of those, I'm going to be expelling contents of my colon out onto my skin. So that could cause a tissue integrity problem. The other type of fistula is enteroenteric, meaning, you know how your colon has loops and they loop on top of each other and they rest on top of each other? Well, if the Crohn's works its way through, causes the irritation all the way through that section of the colon, it can go into the next section of colon, and now I've got a fistula. The problem with having a fistula is it redirects blood supply to one curve, one section. So I can be decreasing function in that one curve or one section. So again, there's good pictures for visuals on page 1158 in your textbook of the interocutaneous and the enteroenteric fistula. And that's one reason why on the Crohn's patient, they need to have a diet that's higher in protein, because the protein will help heal those fistulas, or help prevent them from happening to begin with, because protein helps you rebuild the cells in all of your cell walls in your whole body. So if I'm rebuilding my cell walls, then I have protection against the fistulas from forming. Then if I do develop a fistula, the high protein, increasing my protein will help those heal. So man, let's see, we got to surgery. Now let's get over here to surgery. Surgery, a bowel resection. That's where a diseased section is removed and healthy sections are reconnected. Stricturoplasty. This increases the bowel diameter, because didn't we say that these ulcerative colitis and Crohn's, that as they get inflamed and then they heal, they can develop scar tissue, and that's going to decrease the diameter of my lumens of my intestines. So I can go in and do the stricturoplasty, which is like a balloon, inflate the balloon, and it's going to stretch that bowel, so that opens up that lumen. So what are the differences between UC, ulcerative colitis, and Crohn's disease? Well, I've got it right here. Feature, location. Ulcerative colitis begins in the rectum and can go up through the sigmoid colon, up the whole colon, sigmoid colon, large large intestines. Crohn's disease. It can happen anywhere along the GI tract, but most of the time it happens in the ileum of the small intestine. That's most frequent. The etiology, really it's unknown, or both of them. We are blaming it on genetic factors at this point, and some autoantibody factors. On the age here, under ulcerative colitis, on the age, mark out the 15 to 25 and put 30 to 40. So ulcerative colitis is between 30 and 40, and then there's that gap, and then 55 to 65. Crohn's disease, it's age 15 to 40. The stools, ulcerative colitis, if they're having that fulminant, they can have 10 to 20 liquid bloody stools. So doesn't this show you that ulcerative colitis, I've got to worry about more blood loss? It's possible that the person with ulcerative colitis can have an increased problem with blood loss. Because on Crohn's disease, they can have 5 to 6 loose stools, soft loose stools a day, but they may or may not have blood. And if they do have blood, it would be a small amount. Complications. Ulcerative colitis, you can hemorrhage. Ulcerative keeps making the ulcers and eroding the mucosal lining. Eventually, you're going to get down to the vascular bed and bleed. Crohn's disease, the biggest complication is the fistulas, the enterocutaneous and the enteroenteric fistulas. Need for surgery. Ulcerative colitis, don't usually have to have surgery for that. Crohn's disease, you end up having more frequent surgeries because usually that piece of bowel that has the Crohn's disease is causing so many problems that you have to go in and take that section of the bowel out and re-anastomose the two good ends. Need for surgery, infrequent for ulcerative colitis, frequent for Crohn's disease. Ulcerative colitis does not involve the small bowel, no small bowel. Crohn's disease can be anywhere from the mouth to the anus. Now we're going to talk about diverticular disease. Diverticulitis is the inflammation of one of more diverticula. Diverticulosis is the presence of many diverticula. So diverticula are pouch-like herniations of the mucosa through the muscular wall of the colon. What happens here is you have increased pressure in the intralumen of the bowel. So increased intraluminal pressure. This usually occurs at points of weakness in the intestinal wall. So the diverticula are little pouches that are developed because we've had increased pressure in the bowel. And if you have many of those, you have diverticulosis. Those little pouches now can have where food residue, like husk off the corn, seeds, popcorn, those type of things, get into those diverticula and they cause an infection. And then infection then leads to the inflammation. These little diverticular pouches, they can actually rupture and cause bleeding. So if you have diverticula without any inflammation, you don't have any problems. But when food or bacteria get trapped in them, blood supply is reduced and we can have bacteria start developing and diverticulitis occurs. Okay. Bleeding from diverticula can be minor or they can actually have a massive hemorrhage. Narrowing of the bowel lumen from recurrent diverticulitis can create obstructions, mechanical obstructions. So we'll get to diets in just a minute. Assessment. We're going to ask them about a low-grade fever. Why? It's an inflammatory process. Nausea, abdominal pain. The abdominal pain will be over in the left lower quadrant. Need to know about their stool patterns. Have they been having frequent diarrhea stools, or have they been having trouble having a bowel movement? Are they constipated? Or they could even have some rectal bleeding. Abdominal pain is in the left lower quadrant. It's intermittent, progressing to steady. Because if we've got the food residue trapped in those diverticula and the inflammation process is starting, doesn't it make sense that as the longer the inflammation process goes on, the more fluid, the more edema, the more pressure, the more pain? If the abdominal pain becomes generalized over all 4 quadrants, they may have developed into peritonitis. We're going to get a CBC. We need to know white count because it's an inflammatory process. We need to know our H&H because we might be losing blood. We need to check our platelets because we need to be clotting. Stool for occult blood. Is there any blood in the stool? Because these could be small, slow bleeds too. An upper GI with a small bowel follow-through shows the diverticula in the small bowel. Because remember, the EGD is called the upper GI. It looks at the esophagus, the stomach, and the duodenal area, small intestine. And then a barium enema will have to be used to detect it in the large intestine. KUB, again, that can show, if we've got inflammation going on, it's going to show that the colon is a little bit dilated, like it's bigger. A CT scan, same thing. Medications, antibiotics. We're going to look at Flagyl, Bactrim, Septra, and Cipro. These are all your frequently used antibiotics for this problem. Analgesics. If they're having pain, we need to give them some analgesics. We may want to you want to stay away from the opioids at this point because we don't want to slow down our peristalsis. IV fluids. If they're having frequent stools, then we could be losing fluid. So we've got to replace that fluid. We want to rest. We want to decrease intra-abdominal pressure because that's what caused the diverticula to begin with, was extra pressure. No laxatives or enemas because they increase intestinal motility. Well, it increases, mark out motility, because it increases intestinal pressure. We don't want to increase any type of pressure and cause a rupture. Bowel resection required if peritonitis happens. So if we have a diverticulum that ruptures and we're leaking stool contents out into the peritoneal cavity, we've got to go in and cut that section of colon out to remove the leaking of the feces into the peritoneal cavity. Teach patients to remove or limit nuts, corn, and foods with small seeds from their diet. Your ATI book also has a section over diverticulitis, and they have a list of foods to avoid. Now, we're going to talk about the care of older adults in general when we're talking about the GI system. Incidence of heartburn decreases, but you have more severe complications of GERD. Because they don't have the pain. You know, when we have GERD, we have reflux, we have the inflammation, the irritation, the burning. They may not sense the pain. They may not sense the burning as strong as a younger person. So the GERD may happen longer before they seek any medical attention. We already said Lomotil should not be used in older adults because it causes drowsiness, and then that drowsiness can lead to falls. Worsening dementia may be a sign of peritonitis in an older adult. Why? It's an inflammatory process, an infectious inflammatory process. Their immune system does not react as quick as someone younger. So their problem may be going on longer before they show any symptoms, so they can be having more of a decreased blood pressure, decreased perfusion, and that would be what causes their level of consciousness change. Fever and chills may not be present. Remember, we said their immune response is slow to react, or it doesn't react as strongly. They're going to become dehydrated more quickly. An obstruction may be a problem with older adults occurring as a result of hypokalemia, MI, and infections such as pneumonia, sepsis, peritonitis, and pancreatitis. Because when we're talking about obstruction, we got to have peristalsis, right, to empty out our colon. Well, if they're having trouble with hypokalemia because they're having to take their furosemide because of their heart failure, then their potassium level could be reduced on a more chronic basis, and we need potassium to have muscle contraction. MI, well, that could be decreased blood flow. And infections, they are more apt to get pneumonia, sepsis, peritonitis, and pancreatitis. All right, that is the end of this section of information, and I will load up the next PowerPoint, which will be covering the liver.